begin part 2. In part 2, we have cranial nerve nuclei. In midbrain, you have cranial nerve 3, 4 nuclei, that is oculomotor and trochlear. In pons, you have 5, 6, 7, 8, that is trigeminal, abducens, facial, and vestibulocochlear. In medulla, you have 9, 10, 12. So 9 is glossopharyngeal, 10 vagus, 12 hypoglossal. In spinal cord, you have cranial nerve 11, that is accessory. So these are the cranial nerves. You can remember 3, 4, 5, 6, 7, 8, 9, 10, 12, here 11. So now coming to vagal nuclei. Nucleus tractus solitarius gives the visual sensory information, that is the taste, baroreceptors, gut distension, and it also plays a role in vomiting. The cranial nerves are 7, 9, 10. Nucleus ambiguous gives the motor innervation to pharynx, larynx, and upper esophagus. Cranial nerves are 9, 10. Dorsal motor nucleus sends autonomic fibers to heart, lungs, upper GI, and its cranial nerve is 10. Now coming to cranial nerves and the vessel pathways. Cranial nerve 1 pass through cribriform plate, that is anterior cranial fossa, through ethmoid bone, and cranial nerves 2 to 5, uh, 2 to 6 pass through middle cranial fossa and sphenoid bone. Here you have optic canal, superior orbital fissure, rotundum, ovale, and spinosum. And here comes the posterior cranial fossa. You have cranial nerve 7 to cranial nerve 12, internal auditory meatus, jugular foramen, hypoglossal canal, and also foramen magnum. Now coming to cranial nerve and arteries. Actually, here you need to just see the labeling, that you can do it by yourself. Now coming to different cranial nerves. The mnemonic is, some say money matters, but my brother says big brain matters more. This is to remember which is motor, which is sensory, and which are both like motor and sensory. So here the first cranial nerve is olfactory, it's for smell. Second optic is for sight. Third one oculomotor is for eye movement. Fourth one trochlear, it's for also eye movement. Trigeminal is it's for mastication, facial, and also it activates anterior two-third of tongue and also for loud noises. Next comes abducens, is also for eye movement. Facial is for facial movement. Vestibulocochlear is for hearing balance. Glossopharyngeal is for taste, sensation of posterior one third. Vagus is taste for supraglottic region, swallowing, talking, cough reflex. Accessory is for head turning, shoulder shrugging. Hypoglossal is for tongue movement. Now coming to cranial nerve reflexes, efferent and different. For accommodation 2 and 3, and even for pupillary 2 and 3, for corneal 5, 7, and for lacrimation 5, 7, cuff 10, 10, and jaw jack 5, 5, gag 9, 10. So like that you can remember efferent and efferent. Continue with muscles of mastication. You know, mastication is nothing but like chewing process. So for that you need MMT. M for masseter, M for medial pterygoid, and T for temporalis. You can see the muscles. These are the temporalis, masseter, medial pterygoid. Even you need lateral pterygoid. All these together are supplied by trigeminal nerve. But remember MMT. Medial pterygoid, masseter, temporalis for mastication. Lateral pterygoid is also innervated by trigeminal third branch 5-3. Now coming to spinal nerves. Actually there are 31 pairs. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. The nerves are from C1 to C7, and all these exit above the vertebrae. This is important. But C3 exits above third cervical vertebrae. Like example, C8 exits below C7 and above T1, but all other nerves exit below, like L2 exits below second lumbar. Only the exception is C1 to C7, which are exiting above the vertebrae, but C8 exits below C7 and T1. Now coming to spinal cord lower extent, you know the lower till L2 the adult spinal cord ends, but the CSF ends at the level of S2. So we need to do lumbar puncture from L3 to L4 or L4 to L5, that is below L2, because till L2 you have spinal till L2 you have your spinal cord. So below L2 is better, because we do lumbar puncture to collect CSF. We are nowhere related to spinal cord. So we do below L2. to keep the spinal cord alive. Okay, so the needle passing structures are important in this. The first one is skin, next fascia and fat, next supraspinous ligament, next interspinous, next ligamentum flavum, next you go to the epidural space, next go to dura, arachnoid, subarachnoid. Don't go to pia mater. Last is subarachnoid because in subarachnoid you have CSF and you can collect it there. Now coming to spinal cord and associated tract. Legs are lateral in lateral corticospinal tract. Spinothalamic tracts. One thing you need to know, what are ascending tract and what are descending tract. Ascending tracts are which are going from down to up, like from the spinal cord to the brain. So the name starts with spino like that. Whereas there are descending tracts which are coming from the cortex or from the brain to the spinal cord. So their names start with like corticospinal like that. So that is the difference. You can see descending tracts are lateral corticospinal, sacral, and anterior corticospinal. So from the cortex to spinal cord, so they are descending. Ascending tracts are like you can see here: fasciculus, gracilis, vesiculus, dorsal column, lateral spinothalamic tract, anterior spinothalamic. So all these are ascending. They are going from down towards up. This from the spinal cord to the cortex. Now coming to spinal rock, this the spinothalamic and dorsal column both are ascending. That is, they go from the spinal cord to the brain. So this spinothalamic tract actually carries pain and temperature from the spinal cord to the, and one more thing, whichever is going from the spinal cord to the brain is sensory. Okay, so all the ascending tracts are sensory, whereas descending tracts from the brain to the spinal cord are motor. So here the corticospinal tract is motor, this is descending tract, but spinothalamic dorsal are sensory and they are ascending tracts. So this carries pain and temperature and this decussates at the spinal cord itself. So the name spinothalamic decussates at spinal cord. Next comes the dorsal column. It decussates at the medulla, but it is a sensory, same like this spinothalamic. It is ascending. Next comes to corticospinal. It is a motor now. It is descending. It is coming from the brain to the spinal cord, and this decussates at medulla. And this is a descending. So spinothalamic dorsal are ascending, corticospinal is descending. These both are sensory, this is motor. Now coming to clinical reflexes. So I begin from actually uh, patellar, not patellar. Let us begin from cremasteric reflex L1 L2. Next L2 to L4 patella. Next S1 to S1 to S2 Achilles, S3 to S4 anal wink reflex, and coming to hands C5 C6 brachioradialis, C6 C7 C8 triceps. If it is 0 absent, reflex grading 0 absent, +1 hypoactive, +2 normal, +3 hyperactive, +4 clonus, +5 sustained clonus. Now coming to different primitive reflexes, actually these primitive reflexes can be seen in a healthy infant like up to about 1 year. But after 1 year, usually they disappear because a frontal, like in a mature baby, all this will be going because the frontal lobe is developed. But in some people who have some problem with frontal lobe, then again they show this primitive reflexes. So what is primitive reflex? Moro reflex is like the baby abducts or extend arm when you just tap like this, and rooting reflex is when movement of head is towards the cheek or mouth when you stroke, like when you stroke on her mouth, she will move towards like nipple or towards one side of mother. Next, sucking reflex, in the name you can understand, sucking of milk. So for that, palmar reflex is like, for example, this is my hand. If I put, the baby will just curl her hands around my finger like this. So that is palmar reflex. Next, plantar, same. The legs also she'll be doing like this. Galant reflex is if you stroke one side of spine. Then that will lead to lateral flexion of lower body on stimulated size. So that is gallant. Now coming to landmark dermatomes, from back to anterior, posterior half of skull is C2, C3 this one anterior turtleneck shirt, C4 is collar shirt, C6 is like thumbs up, so 6, T4 is nipple area, T7 is skiphisternum point, T10 is umbilical point, L1 is inguinal ligament, and L4 is kneecap, and S2, S3, S4 all come to penile anal back region. Now coming to pathology of nervous system. So here you should need to see prefrontal cortex. Here you have frontal lobe syndrome. Like if you lose frontal lobe, already we discussed, they'll behave like primitive. They show all the primitive reflexes again, and they have a kinetic mutism. They have hyperphagia, loss of empathy, all these things. Continue with frontal eye fields. Frontal eye fields is like where you got brain problem, towards that side your eye looks. Next, paramedian pontine is opposite to that, like where you got brain lesion, to opposite to that your brain look, I mean your eyes look. Next, dominant parietal cortex is if you get problem here you get just man syndrome. Like I remember this is a just man who can't calculate, who can't draw graphs, a finger problem, and right and left disorientation. Next, non-dominant parietal cortex is hemispatial neglect. Like half of the body will be lost in contralateral agnosia of side of the world. Basal ganglia, you get tremor at rest itself, and you get chorea athetosis. Athetosis, chorea are associated with Huntington and Parkinson disease. Subthalamic nucleus will cause contralateral hemibellismus. Mammillary bodies, it is affected in Wernicke-Korsakoff alcoholic syndrome because of thiamine deficiency. Amygdala, bilateral lesions, Calver-Bussy syndrome. They have hyperphagia, hypersexuality, hyperorality problem, also seen in HSV1 encephalitis. Hippocampus will lead to bilateral lesions, like it will cause anterograde amnesia. That is, you can't remember new memories. Okay, it is seen in Alzheimer's disease. Dorsal midbrain is affected in paranoid syndrome, where there is pineal gland tumor. Reticular activating system reduce the levels of arousal and wakefulness. Coma. Medial longitudinal fasciculus will lead to internuclear ophthalmoplegia, like impaired adduction of ipsilateral eye and nystagmus of contralateral eye with abduction. Only one eye will be moving and the other eye will be still in adduction. That is towards the medial side, other eye will be towards the lateral side. So that is seen in multiple sclerosis patients. Cerebellar hemisphere, it is intention tremor. You can differentiate from basal ganglia by tremor at rest. Okay, and here you have lymphattaxia, loss of balance, and also damage to cerebellum. Always leads to ipsilateral defects. And cerebellar hemispheres, laterally they'll affect lateral limbs. Medially they'll affect the central body. Like there's wide base, drunken gait, nystagmus, dysarthria, and it is also associated with chronic alcohol overuse. Now coming to decorticate and decerebrate. Decorticate is flexor positioning, which is above the red nucleus, the lesion. Here the overactive tracts are rubrospinal and retrovestibulospinal. The presentation is they have upper limb flexion, you can see, and the lower limb is extended. So the mnemonic is your hands are near the core after the heart. So decorticate. Decerebrate is extensor. You can see it is between red and vestibular nuclei. This the affected tract is vestibulospinal. Here both upper and lower limb are extended, and it is having worse prognosis. Now coming to ischemic brain disease or stroke. So actually the mnemonic here is most vulnerable hippos need pure water. So vulnerable is for vulnerable organs, hippo is for hippocampus, need is neocortex, pure is Purkinje cells, water is watershed areas. So all these regions are having higher chance of ischemic stroke. We can do CT and MRI, but CT detects ischemia within 6 to 24 hours. It's somewhat longer time, but diffuse weighted MRI you can see the ischemia within 3 to 30 minutes. Okay, and you need to see this process, what happens after brain ischemia. First, within 12 to 24 hours you will get eosinophils and pyknotic red neurons, whereas in 24 to 72 hours you get necrosis, neutrophils. For 3 to 5 days macrophage, same like normal inflammation. After 1 to 2 weeks you get reactive gliosis, which is done by astrocytes. If you remember in the part 1 I talk about astrocytes. Greater than 2 weeks you will get glial scar. Okay, now coming to ischemic stroke. Ischemic stroke is nothing but you get ischemia, so because of that you get infarction. Especially if you remember, in the brain we get liquefactive necrosis. Okay, so there are three types by which you can get this stroke: either thrombotic, embolic, or hypoxic. Thrombotic, coming from like the blood clot has formed in the same vessel, so you got, and here you will get pale infarct. Embolic from somewhere, especially from left artery, you may get like in atrial fibrillation case, and that emboli has come and struck in the brain and it has caused red infarct. Hypoxic is of course low oxygen supply, so watershed areas get affected and you may get ischemic stroke. So treatment is to give TPA, okay, and reduce risk with medical therapy, and monitor blood pressure, smoking cessation, and treat conditions like which increase risk like atrial fibrillation, carotid artery stenosis. Transient ischemic attack is like if you get the same stroke but which is less than 24 hours and it is getting resolved within a short period of time, then that is called transient ischemic attack. And in transient ischemic attack, the characteristic feature is hemorrhagic fugax, that is suddenly you lose the vision and after some time you get your vision again back when the stroke has gone away. Now coming to cerebral edema, you may get edema in brain because of two reasons. Either the pump has lost, sodium potassium pump, or because of some extracellular fluid is getting accumulated because of rupture of blood brain barrier. So these are the two causes which can lead to increase in intracranial pressure, of course because of edema in brain. Now coming to effects of stroke, we know when anterior cerebral artery goes, your legs contralateral side of leg affected. If middle cerebral artery, same contralateral of your upper extremity and face. If lenticular striate artery, contralateral paralysis with sensory features. Okay, that is important. It's a pure motor stroke, most common location lacunar infarcts. Okay, here you need to see contralateral paralysis, absence of cortical signs like neglect, aphasia, visual field loss. Okay. Now coming to posterior circulation, you know if there is PCA, you get all visual problems. If basilar artery, you get locked in syndrome, like you get loss of voluntary facial, mouth, tongue movements, loss of horizontal, vertical eye movements. So all your face got locked when basilar artery goes away. And when ICA goes away, you get lateral pontine syndrome, where facial nerve nuclei affects specific to ICA. Okay. And when you get pica, you have lateral medullary or Wellenberg syndrome, where nucleus ambiguous affects pica. Okay, and they get dysphagia and hoarseness as the main symptoms when pica is gone. I mean, when there's stroke in pica, and when there's stroke in ASA, they get medial medullary syndrome because of paramedian branches of ASA get infarcted. Okay. Neonatal intraventricular hemorrhage. Actually, you know, in the ventricles we should have CSF, but sometimes blood may come and fill and they will enlarge the ventricles and, of course, raise intracranial pressure. That is seen in neonates, and that is neonatal intraventricular hemorrhage. Now, coming to intracranial hemorrhages types, epidural, you know, upon the dura mater, you get lens shape like this, and this is having characteristic lucid interval, and here this CT shows lentiform, you can see. Lucid interval is characteristic for epidural hematoma. That is, they suddenly lose the consciousness, again after some time they'll get it back. So that is seen here mainly. Next, coming to subdural, it's below dura mater, you get hematoma. Like it is between dura and arachnoid. So here the bridging veins, the main thing is the bridging veins rupture here. And you can see shaken baby here. They actually can get the crescent shape hemorrhage here which crosses the suture lines because it's subdural. Now some arachnoid we know in the subarachnoid space, if you get hemorrhage, that will lead to scanthochromic blood or yellow, bloody or yellow color scanthochromic lumbar puncture, and you get worse headache of the life in subarachnoid hemorrhage. Intraparenchymal, and one more thing, subarachnoid hemorrhage is associated with berry aneurysm. Intraparenchymal hemorrhage is associated with Charcot-Bouchard aneurysm, which is inside. You can see that's why the name intraparenchymal, inside the brain. Okay, and it's most commonly caused by systemic hypertension. Central post-stroke pain is like after brain stroke, you get pain. That pain is with altered sensation and occurs and you get paresthesias and orderly painless may cause pain. Okay, phantom limb pain is like after amputating one limb you get the pain and you still feel the limb is present. Diffuse accidental injury is like someone got motor accident, then they may have chance to get this. Usually MRI shows punctate hemorrhage in diffuse accidental injury. Now coming to aphasia. Aphasia is you lose the ability, higher order deficit of language. Dysarthria is like you have everything knowledge, just your motor inability to produce speech, that is dysarthria. Let us see types of aphasia. You have Broca, Wernicke, conductive, and global. Broca is like you are talking, like you are asking what is his name, and that boy is saying, but he is unable to say it fluently, like you say like that. So that is Broca. What is Wernicke? Wernicke is like if you ask name, that person may say I went to park like that. So they are like not associated with our words. So that is seen in Wernicke. And global means both together. That is completely mute patient. Conduction means there is damage to arcuate fasciculus that will lead to conduction problem. Now coming to aneurysm, you have saccular aneurysm, Charcot-Bouchard. Saccular is nothing but berry Why you get aneurysm is because the blood vessel will get slightly thinner, so that the blood will bulge out like a berry, and this is seen most commonly in the junction of anterior communicating and anterior cerebral artery. This is associated with some diseases like autosomal dominant polycystic kidney, ALS, Danlos. Other risk factors like advanced age, hypertension, tobacco smoking. So actually they are silent, but if they rupture, they cause subarachnoid hemorrhage, which is thunderclap headache or worst headache of my life. And these symptoms may compress the other surrounding structures. So you have ACOM compression, which will cause bitemporal hemianopia because of compressing optic chiasm. So there will be visual acuity deficits. And if this ruptures, it will cause ischemia in anterior cerebral artery. So then, contralateral lower extremity may get hemiparesis. Next, coming to MCA, if it gets ruptured, it will cause ischemia, and this will lead to contralateral upper extremity and lower facial hemiparesis and also sensory deficits. If posterior communicating artery gets compressed, it will cause ipsilateral cranial nerve 3 palsy, that is down and out eye, also miridiasis, that is dilation of pupil, and also tosses is seen. Okay, very important. Now Charcot-Bouchard already we know intraparenchymal hemorrhage, right? It is associated with chronic hypertension and affect small vessels and cause hemorrhage. Okay. Now, fever versus heat stroke, how to differentiate? Fever, it's because of cytokines during inflammation. Heat stroke is because you're not able to send heat out of the body, and here the fever temperature less than 40 degrees, whereas heat stroke greater than 40. Here, if the fever is more, it will cause seizures like benign but self-limiting. But if heat stroke is more, you get confusion, rhabdomyolysis, acute kidney injury, ARDS, and also DIC, very dangerous. So the management of fever is you can give acetaminophen or ibuprofen for comfort and also antibiotics. But if you get heat stroke, you should do rapid external cooling, rehydration, and next you should do electrolyte correction. Now coming to seizures. Seizures are divided into partial seizures and generalized. Partial are again divided into simple partial and complex partial. In simple partial, they have consciousness that they know they got seizures. In complex partial, they don't know that they got seizures, that is impaired consciousness. Epilepsy is nothing but you get repeated seizures. Status epilepticus, like you get continuous seizures greater than 5 minutes and it is not returning again back to normal continuously. If you get seizures, then it will also lead to brain injury. Now coming to generalized seizures, you have absence, myoclonic, tonic, clonic, tonic, atonic. So absence seizures is like suddenly they stay for some time, like about 3 hertz spike of current wave discharge, and again they come back to normal. They have blank stare with no confusion, and this can be triggered by hyperventilation. Myoclonic seizure is quick, repetitive jerk, but still they have consciousness. Tonic clonic is called grand mal. They have a lot of stiffening, they have post-ictal confusion, they show urinary incontinence and also have tongue biting. Tonic is stiffening, atonic is like drop on floor. Okay, so what are the causes of seizure in children less than 18? The chances are genetic, infection, trauma, congenital, metabolic. In adults like 18 to 65, it's because of tumor, trauma, stroke, infection. In adults greater than 65, the chance is again stroke, tumor, trauma, metabolic infection. So almost the causes are same in whatever the age it is. Now coming to headaches. Headaches are like divided into many types. like because of irritation of intra or extracranial structures you may get. So coming to headaches, we have cluster migraine and tension headache. Cluster headache is unilateral, it lasts from 15 minutes to 3 hours and it's repetitive. So actually you get pain around your eye, that is periorbital area pain, and it's called suicide headache because it has autonomic symptoms like lacrimation, rhinorrhea, conjunctival infection, and sometimes it is also associated with Horner's syndrome. This is more commonly seen in males, and the treatment is sumatriptan, 100% oxygen, and also can give prophylaxis as verapamil. Now coming to migraine, it is also unilateral pain, but it lasts for longer time. You can see like 4 to 72 hours of severe pain. It is pulsating pain with nausea, photophobia, phonophobia, like they don't want to have light, they don't want to listen to any sound, and they may also have aura, and there's irritation of cranial nerve 5, meninges and blood vessels all are affected, and substance p calcium gene related peptide, these are the vasoactive neuropeptides which also get released during migraine. So treatment is NSAID, triptans, can give beta blockers, uh, like valproate, botulinum toxin, all this can be given. But the main treatment is NSAIDs, triptans. Now coming to tension headache, you can see it's like a band-like headache, bilateral headache greater than 30 minutes. It is steady band-like, but there's no photophobia or phonophobia, and even no aura like migraine. Okay, and here the treatment again you can give NSAIDs, acetaminophen, and for prophylaxis you can give TCA and behavior therapy. One more thing is trigeminal neuralgia. It is a repetitive unilateral shooting like pain because of problem in third cranial nerve, and this is triggered by chewing, talking, touching parts of face. So it will last from seconds to minutes, but episodes often increase in intensity and frequency over time. First line treatment is carbamazepine. Very important to remember. Actually, carbamazepine is also used as an anti-epilepsy drug. Okay. Now coming to movement disorders, akathisia is like restlessness and intense urge to move. Like they want to always move, and this can be seen with neuroleptic use or as an adverse effect of Parkinson treatment. Because Parkinson people don't move, so if you give some treatment, over treatment to them, they'll start moving like more. That is akathisia. Next, astraxis is extension of wrist, cause flapping movement. It is associated with hepatic encephalopathy, Wilson disease, and metabolic derangements. Next, coming to athetosis, it's a slow snake-like breathing movements of fingers seen as a problem of basal ganglia, seen in Huntington disease. Okay, Korea also in Huntington disease. Here also basal ganglia is affected. Here there are sudden, jerky, purposeless movements, like people in Korea start dancing some meeting, so it's like unpurposeful moment. In acute rheumatic fever, this in the Korea. Now coming to dystonia. Dystonia is sustained voluntary contractions of muscle. It is writer's cramp, spasm, torticollis. Treatment is botulinum toxin injection. Essential tremor is high frequency tremor seen when they are anxious. You can give. They actually self-medicate with alcohol, but the treatment is beta blockers and barbiturates, propranolol and primidone. Intention tremor, we know it's seen in cerebellum. Problem zigzag motion when pointing towards a target. Resting tremor, Parkinson disease. Okay, hemiplegismus is like opposite part is affected because of subthalamic contralateral nucleus. Myoclonus is sudden uncontrolled muscle contraction like hiccups, jerks. Okay, and it is associated with Creutzfeldt-Jakob disease. Restless leg syndrome is like people just move their legs, otherwise they feel uncomfortable. This is associated with iron deficiency, chronic kidney disease, diabetes, neuropathy. Treatment is dopamine agonists like pramipexole and ropinirole. Now coming to neurodegenerative disorders. So here there's a decrease in cognition, ability and memory, but the consciousness is intact. So we need to rule out either it's because dementia is because of depression or because of hypothyroidism or vitamin B12 deficiency or maybe neurosyphilis or normal pressure hydrocephalus. So first let us see Parkinson disease and mnemonic is TRAP, that is they have tremor, rigidity, akinesia, postural instability, shuffling gait, small handwriting, and there's also dementia, but it's late finding. People who use drugs, they have MPTP, toxic substance, which is metabolized to MPP plus in our body, and this is toxic to substantia nigra. That's why you get Parkinson disease, because in Parkinson's disease, the problem is loss of dopaminic neurons in substantia nigra. And there's also accumulation of Lewy bodies, which is made up of alpha synuclein. Okay, now coming to Huntington, it's a trinucleotide repeat disease. CAG repeats. So here C is that caudate lobe is lost, so you get ventriculomegaly. A is acetylcholine is lost, and G is for GABA loss. Okay, Huntington disease have four, like Hunt have four, and HTT is four. You have choreoathetosis, aggression, depression, dementia. Here the dopamine is rise, GABA and acetylcholine are decreased, and there's atrophy of caudate or putamen with ex vacuo ventriculomegaly. Ex vacuo means the brain size is decreased. Okay, Alzheimer's disease, it can cause dementia in older adults, and people with Down syndrome have increased risk of early onset Alzheimer's. It is associated with E2 will decrease risk, E4 will increase risk, and Preslin 1, Preslin 2 have chance to increase risk. Widespread cortical atrophy is seen in Alzheimer's disease, especially hippocampus get affected and the gyri become narrow, widen of sulci. You get senile plaques of beta amyloid core because A beta amyloid get accumulated here. There are also neurofibrillary tangles, which you see in Alzheimer's. These are intracellular hyperphosphorylated tau proteins, and there are also Hirano which are also intracellular eosinophilic rods rich in hippocampus. Coming to frontotemporal dementia, frontal and temporal lobe are lost. Of course, frontal means all the motor functions are lost, temporal means hearing is lost, and also the Wernicke's aphasia you can get here. This is called Pick's disease. Okay, frontal and temporal together, Pick's disease. You can here get hyperphosphorylated tau pig bodies, ubiquinated TDP43. Now coming to neurodegenerative disorders, you have Lewy body dementia. That is, the Lewy bodies actually get accumulated in the brain and causing dementia. You may get REM sleep behavior disorders, and also you may get dementia secondary to Parkinson disease, that is Lewy body dementia. Next, you get vascular dementia, that is because of multiple arterial infarcts. Stepwise, there's decline in cognitive ability and also memory impairment. Second most cause of dementia in older adults, because in older people, slowly the blood vessels weak in the brain, so they get less blood supply and they have memory loss. Creutzfeldt-Jakob disease is also may cause dementia, but here the increase in 1433 protein in CSF is the problem, and it's because of transmission by contaminated materials like corneal transport, neurosurgical equipment. Spongiform cortex is vacuolation without inflammation, and prions get accumulated. HIV associated, already giant cells are present in HIV patients because of microglia. They lead to cognitive deficits, gait disturbance, irritability, depressed mode.